Talking about fetal monitoring in the labor, for this one, you have to check the vaginal examinations. Then again, don't do too much. So prevent the prevention, membrane status as indicated by the amniotic fluid, cervical effacement, dilation, consistency, positioning, and application, fetal presenting part, location. So everything we will check according to that one. Then intrapartum fetal monitoring, we'll be checking the Doppler device checking for every 15 to 20 minutes, 30 minutes, sorry, for 1 minute, as we already see in many of the MCQs that how they do like to ask these questions for 1 minute, for how many time, for how long. This is something tricky. In active phase of the first stage. So in which stage and for how long, and for every 15 to 30 minutes for 1 minute in the active phase of the first stage, then every 5 minutes in the second stage. So you can see that how the difference it is. The continuation of the fetal heart rate, checking for the induced augmentation, meconium present, multiple gestation, use of the continuous electronic monitoring, then technique for the continuous monitoring of the external Doppler, internal fetal monitoring. So checking for bradycardia, acceleration, deceleration. Fetal scalp monitoring should be used in conjunction with the electronic fetal heart rate monitoring, contraction monitoring. Then the electronic fetal heart rate monitoring is basically measured by the Doppler, contraction measured by the tachometer. Then the baseline fetal heart rate normal range is 110 to 160 BPM. Parameter of the fetal well-being versus distress. In this one, going for variability, periodicity. Variability, how much it should be. It should be between 6 to 25 minutes for 15 minutes. Can be assessed with the CTG. So usually we go for the CTG. Then the periodicity is basically there should be acceleration, there should be no deceleration. So increase of more than 15 second. 3 deceleration described in shape, onset, depth, like how it is, how long it is going in for, how deep it is. So more than everything, you need to know the causes of it. That's very, 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 very important. And especially talking about the tachycardia, because and then you can remember the maternal causes, how they got the tachycardia. If you have fever, infection, anemia, dehydration, you do get the tachycardia. How, when did they get the bradycardia? When they have hypothermia, hypoglycemia, hypotension, like everything is low. So in that case, is go for the bradycardia. When is variability? There is infection and then there is dehydration. Like before it was tachycardia, now later on starting for bradycardia. Fetal factors in fetal tachycardia. When is the fetal tachycardia? Like anemia, infection, we already know, hypoxemia, and congenital one. Then bradycardia is basically when there is hypoxia, vagal stimulation, dysrhythmias, hypothermia, acidosis. Variability is basically CNS anomalies, dysrhythmias, preterm fetus in those ones. Drugs where there is stimulants, bradycardia where there are destimulants like beta blockers and anesthesia. And variability where it causes both of them. Uteroplacental insufficiency, it's very, 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 very important. If you don't cannot remember the maternal, the fetal, at least remember the uteral one. When does the uterus causes or uterus have an impact on the fetal tachycardia? When there is hypoxia, like abruption or hypertension, or there is an infection, like chorioamnitis. When do it cause bradycardia, like late hypoxia, acute cord prolapse, hypercontractility? When does it cause variability? It causes the hypoxia. So you don't have to go into very detail of it. Just knowing a bit of this one, it would be more than enough for you. Now, when we are talking about this one, in this one, you need to remember the causes. The early deceleration is very benign due to the vagal response to the head compression. And I hope you guys have an idea of how does the early deceleration works. So the variable deceleration due to the cord compression, or in the second stage, or forceful pushing with the contraction. In that one, there is variable deceleration. So it is a very straightforward questions, or these pictures can be given and ask you what could be the cause. So if you don't know how does it work, so let me give you a little bit of example. So this is basically fetal heart rate. Now this is basically a uterine contraction. So this is the one dip from the top, like we are talking about this one fetal heart rate. This is basically, it should be above, like high. It's basically acceleration, the one that's on the top. But if there is a dip, then let me write down, wait, just me a second. If there is a line, right? If it's going on here, it's basically good. Then there is one up, it's basically an acceleration. And if it's going down, then it means it's a deceleration. Okay. So you see, as compared to this one, here it's a basically deceleration. How do you say this is early deceleration or late deceleration? When you compare this one with the uterine contraction. So if it's coming, the uterine contraction is coming like this and it's going along with it. Okay. So it's basically, you can see the onset of acceleration and the onset of contraction. It's along with it. It's basically early deceleration. When it is not matching with it, it's variable deceleration. And just give me a second. So just give me a second. So when you can see this one is not aligned with it, then it's basically variable deceleration. And when it's displaced away means you can see this is late deceleration. Okay, just this much you need to remember. That's about it. Two lines are there. Above one is fetal heart rate, below one is contraction. If this is in a line with each other, it's early deceleration. If there is no pattern, like not even the depth is equal, so in that case, this is basically variable in this regard as well, in this regard as well, in the vertical way, in the horizontal way. But when it comes to late deceleration, you can see the depth is equal, but they are not in align with each other. So it's basically late deceleration. That's about it. Okay. So we already know the early acceleration is good. So we are talking about the deceleration. So early deceleration is in the head compression. Variable deceleration is in the cord compression. You have to remember it on your fingertips. Okay. Then complicated variable deceleration is present in the fetal acidemia. That's basically very unlikely they will ask you, because fetal complicated variable deceleration is hard to tell from the pictures. It's mainly obstetrician that usually go along with it. Then the late deceleration is basically uteroplacental insufficiency. So these words you have to keep it in your head or keep it in your fingers so you can do the diagnosis right away. Then the rule of the 60 suggestive swear variable deceleration acceleration for less than 60, more than 60 second with the slow return of the baseline. This is basically swear. So in that case, this is going on for too long. Then fetal scalp blood monitoring. In this one, we check for the cervix is already dilated. Checking for fetal heart rate is abnormal. So in that cases, we go for that, checking for the lactate if there is any acidemia going on or any acidosis going on. Then we don't do it is basically in the blood dyschariasis because the bleeding will not stop. Fetal oxygenation, we already discussed. Fetal oxygenation is one of the thing where there is like a uterine blood, placental blood flow is disturbed. So that's why it's happening. Fetal response to the hypoxia, decreased movement, tone, and breathing activities, anorexic movements, fetal bradycardia could be there, and fetal blood flow is there. And mainly the effect is going towards the heart. So this can be asked if there is an oxygenation problem, which are the organs that gets the increased blood flow, which are the organs that get the decreased blood flow. It's very important. Then we are talking about the factors affecting fetal oxygenation. What are those ones where the contraction is the problem, hypotension, the bleeding is issue, oligohydramnios, cord prolapse is there, like any way where the blood is being compressed and not affecting, reaching to that point. So you can see the maternal, uteroplacental, and then fetal. Then coming to the induction of the labor and augmentation of the labor. Induction, so you need to know all the causes where you have, like, what are the conditions where you do the induction of the labor. Okay, so you need to remember all of the conditions. Induction is indicated when the risk of continuing exceeds the risk of continuing exceeds the risk of having the induced labor. So induction and augmentation, induction is basically starting and augmentation is helping, just for your idea. So consider the following before induction. So what are those ones that I told you? Indication for the induction, contraindications. You have to know which are the indications, what are the contraindication. Gestational age, cervical favorability, fetal presentation, potential for the CPD, fetal well-being, and the membrane status. This can be asked in the MCQs. What are the conditions? And then they can give you one or two, or they can ask you what are the conditions that you will look before going for the induction, and then imagine they can give you all of them, and then in one answer this says all of the above. Okay, so in MCCQE1 they sometimes give you more than 4 or 5 options as well, and there is an E, and then there is F as well, so you never know. The prequisition of the labor induction, capability of cesarean delivery if necessary. Maternal is basically when the cervix is ripe. If cervix is not ripe, use prostaglandin. Which one? The prostaglandin vaginal insert or the gel can be used. Misoprostol and the Foley's catheter can cause the induction. Then fetal is that case we check for the fetal heart rate, cephalic presentation, and all that. Then the success rate is where the cervix favorability is basically unfavorable, favorable, or score for 9 to 13. So how do you check for the cervix one? The Bishop score. What is the Bishop score? Position, consistency, effacement, dilation, and then station. And they can give you an exam question where they give you these values and ask you to calculate it or ask you if you are going to do the induction of labor or not. So you need to know for the position, if it's anterior, the point is 0. They can give you a mild one with the medium consistency. The effacement is this, dilation is this, and the station is -1. What is the next step that you will do? So if you are not able to calculate, you will not be able to move on. What do you do for the next one? So here you can see if this is less than 6, it's basically unfavorable. More than 6 is favorable. 9 to 13 is a vaginal delivery. So if you're not able to calculate, you will be finding it hard. Late term and postpartum, most common causes is basically the reason is there for induction. 39 to 41. Usually we start the induction, we have to check for the stillbirth. More than 41, we do induction of the labor to decrease the cesarean delivery, fetal heart rate, meconium, macrosomia, or the death. More than 41 and expected management elected. In that cases, you have to check for the fetal surveillance, like checking for heart rate if there is any compression. Then BPP every 3 to 4 days. Maternal factors, basically diabetes, gestational, preeclampsia, medical factors like where there is outcome is more dangerous than this one. The labor induction may be offered to the patient age more than 40 at more than 39 gestational age due to increased risk of stillbirth. Then what are the factors? Don't forget about the ROGAM. I keep on mentioning that one. Then isomerization from choriomonitis. Fetal factors are basically fetal jeopardy. Like fetal is basically in the verge of death. Macrosomia, fetal demise, IUGR, polyoligohydramnios, and then stillbirth or the low PAP A.